Pheochromocytoma is a tumor arising from the chromaffin cells of the adrenal medulla, and it releases epinephrine, norepinephrine, dopamine, basically the catecholamines. So the patient presents with a triad of headache, palpitations, and sweating. And the different effects on the organ systems are: on the cardiovascular system, the patient will have arrhythmia, tachycardia, and the patient can have cardiomyopathy. And on the respiratory system, the patient can have pulmonary edema because of left ventricular failure induced by catecholamine release. And the patient will be in a volume contracted or fluid contracted, plasma contracted state. And metabolic, and the patient will have hyperglycemia because catecholamines cause inhibition of the insulin release. So the patient will have hyperglycemia. So these are the symptoms the patient presents with, and these are the effects on the different organ systems. And before the surgery, we want to prepare the patient. So how do we prepare the patient? So preparation of the patient before the surgery will take at least 10 to 14 days. So first we are going to do an alpha blockade, followed by a beta blockade, and also we're going to treat the volume contracted status. So why do we aim for an alpha blockade before a beta blockade? Because if we cause a pure beta blockade, it will cause unopposed alpha action, and that will cause a hypertensive crisis. So we want to prevent that hypertensive crisis. So we want to prevent that. So we're going to start on an alpha blockade and then come to a beta blockade. So alpha blockade is done by non-selective alpha blocker like phenoxybenzamine or phentolamine. So after adequate alpha blockade, we're going to move on to the beta blockade, which is done with propranolol, esmolol. Not esmolol, esmolol is short acting, so esmolol is used intraoperatively. So pre-op beta blockade is done by propranolol and metoprolol. Propranolol is given in the dose of 10 to 40, metoprolol is given in the dose of 25 to 50 mg. And for the volume contracted state, we're going to give fluids to the patient, encourage oral hydration, and salt intake, adequate salt intake. So we are going to prepare the patient, right? So how do we know that the patient is adequately prepared? So that is given by Roizen criteria. So according to Roizen criteria, so we look at two main things in Roizen criteria. We look at the BP and we look at the ECG. So for BP, we want to make sure that the BP is less than 160 by 90 millimeters of mercury, and the patient does not have orthostatic hypotension, or the BP should be more than 80 by 45 millimeters of mercury. And from the ECG, we want to make sure that the patient does not have ST changes in the past 1 week. And also the number of PVCs should be less than 5 per minute. So if these criteria are met, we know that the patient is adequately prepared. So intraoperatively, what are our concerns? So during the tumor manipulation, there is catecholamine release, and that can cause hypertensive crisis. And after the tumor is resected and the adrenal vein is ligated, there will be a sudden fall in catecholamines, and that can cause hypotension. So our goals intraoperatively are to prevent the hypertensive crisis, and after the adrenal vein is ligated, we want to prevent the hypertension, and also we want to maintain the volume status of the patient because they're in a volume contracted state. So these are the drugs that we use intraoperatively. When the patient has a hypertensive crisis, we can use sodium nitroprusside, nitroglycerin, nicardipine, and if this is not enough, we can even use an alpha blockade, a phentolamine. And to treat tachycardia, we can use a short-acting beta blocker like esmolol, 0.5 mg per kg. And to treat the hypertension after the tumor removal, we give vasopressors, norepinephrine, epinephrine, and vasopressors. So there are certain drugs that we have to avoid in this case, like ketamine, which is a sympathomimetic. Pancuronium causes tachycardia, so we avoid it. Halothane is arrhythmogenic, even with a lower dose compared to the other inhalational agents. Ephedrine, metoclopramide also cause increase in catecholamine release, so we avoid it intraoperatively. And this is a flow chart that tells us about the whole thing. So pheochromocytoma surgery, so preoperative preparation, we first aim for an alpha blockade followed by a beta blockade, and the volume expansion is done. And then adequacy is checked by the Roizen criteria. And intraoperatively, during induction, we want to prevent the intubation response and the sympathetic stimulation. And for induction agents, we use propofol, and we can blunt the sympathetic response by using fentanyl, esmolol, lignocaine, 1.5 mg per kg. And during the tumor handling, we want to prevent the hypertensive crisis with vasodilators. And after the vein ligation, there is a fall in catecholamine, so we're going to treat the patient with fluids and vasopressors. And post-operatively, the patient should be monitored for 24 to 48 hours, because they have increased chances of complications like hypertension because of the catecholamine fall, and hypoglycemia because pheochromocytoma causes the catecholamine release, which inhibits insulin release. So the patient will be in a state of hyperglycemia before, but after that, after the fall in the catecholamine levels, the insulin levels rise, as a result of which the patient can develop hypoglycemia.